thiopental, propofol, ketamine, Brevitol. Did I say etomidate already?
No.
And etomidate. So that's just 10 drugs, and 4 of them are gases. Precedex I'll mention, but it doesn't work with GABA or NMDA. So try to think of it in that perspective so it's not so overwhelming. We're just having 10 drugs that we're looking at. So if there's an answer on the test that's not one of those drugs, it's probably a distractor, like the sigma receptor or the mu receptor, right? So trust yourselves. So a couple classes ago, Mr. Fortner was sitting right there. He headed up a group of people that I can send it out if you're interested. So that's where this comes from. It's an Excel spreadsheet that gives you a reference dosing kind of guide. And it also gives you some really cool, good to know, quick facts. For example, when you look at thiopental, has anybody here ever seen that drug? Well, it works on the GABA receptor, just like the propofol, just like the etomidate, the Brevitol, and the midazolam. All of those guys work on the GABA receptor. And so with thiopental, the cool thing about this little chart is that it tells you the concentration that you typically put it in. It tells you the typical induction dose, what the onset is. In this case, you inject thiopental. It's not like the gases, is it? You inject it, and people go to sleep. There is no compartment filling. There's no towel. There's none of that crap. You inject it into the IV system, people go to sleep. T1/2 alpha. That's also known as your redistribution half-life. Are you familiar with that?
Yes.
Okay. And then you have a clinical duration of action. The clinical effect in this case would be hypnosis or sleep. You have a T1/2 beta. What do you think that is? Clearance, elimination. Yep. And it gives you just a quick down and dirty of where it's eliminated at. And finally, the mechanism is over at the end. So the drugs that are yellow, they activate the GABA receptor, the GABA agonist. Midazolam, which is orange, is this allosteric modulator of the GABA system. And ketamine, which is yellow here, is an NMDA antagonist. So that was the purpose of that last question today on your exam, to show you that we're talking about 2 big categories of drugs, ones that activate the GABA receptor and ones that block the NMDA receptor. And there's only one drug that blocks the NMDA receptor, and that's ketamine. Yes, Precedex is in some of the chapters as an induction agent. But not a lot of people use it for induction. The dosing is a little complicated. And what else do you know about Precedex?
It's really expensive.
It's expensive. And there's better drugs, exactly, side effects, and there's better drugs to get the effect you want. It's hard to beat propofol. It's really hard to beat the effect you get from propofol at the price. But Precedex does activate this alpha-2 receptor. Are we feeling a little bit better about this block? There's none of this gas compartment, towel. And I'll get you chapters. There's plenty of chapters out there to read on these drugs. So, what do we know about these drugs? Are they lipophilic? Yes. That's great for the redistribution half-life. But this graph is saying, what happens when I give a long infusion and then turn it off? How long until I have a half-life, a context-sensitive half-life, or half-time? And what that means is for example, looking at propofol, and we'll cover this again. If I give propofol for an extended duration of time, let's say I infuse it for 6 hours, how long until 50% of it is gone from the blood? That is what that y-axis means. How long until 50% of it is gone from the blood? So after a 6-hour infusion of propofol, for those of you that have been on the ICU, you did this all the time, right? 6, 12, lots of hours of propofol. Write the order overnight so I don't have to worry about the patient. They'll be asleep. So we're talking 25 minutes until 50% of that is out of the blood. That's pretty good for propofol. But if you give something like midazolam over an extended period of time, and you did that in the ICU too, think about how long it is till you got a patient that is somewhat responsive. So that is what that means. And this is a nice graph to show you the different induction drugs. Do we use Valium anymore for induction? No, it lasts way too long. It lasts way too long. And again, what are the 2 receptors that I'm focusing on for this block? GABA and the NMDA receptor. And what do you know about the GABA receptor when it's stimulated? It opens a chloride channel, and where does that chloride go? Intracellularly, you get a hyperpolarization and the cell stops working. What about the NMDA receptor? Do you know much about that one? Not much. So this is the N-methyl-D aspartate receptor. So N-methyl-D aspartic acid, right, or glutamate, will bind to this receptor and create an excitatory phenomenon. So what do you know about glutamate in the central nervous system? It's the major excitatory neurotransmitter in the central nervous system. So if you block this receptor, do you see how you can become sedated? Right? So that's the big picture for those. Now here's another picture of the GABA receptor to show you the configuration of this receptor. How many subunits does it have? It has 5 subunits. And so we see that the GABA site is up here. But remember I said midazolam is an allosteric modulator? Do you see where its site is different? And we'll discuss that. So this picture gives you a nice sense of where these molecules might be binding. And now here's the NMDA receptor. It's a bit of a complicated receptor, and we'll discuss it. But just know that it has several binding sites and can be acted on by several things. But what's the important thing for us in regards to this receptor? We give what? Ketamine, and it blocks the channel. It actually blocks it on the inside. This PCP MK801 site, ketamine is a phencyclidine derivative. And what is PCP otherwise known as? Angel dust, which is a phencyclidine. So it's related to angel dust, related to LSD. And if you give a supra-therapeutic dose of ketamine, you're going to have a patient that will act pretty strange, transiently. Now, if you can remember back to the first lecture on the inhaled agents, we talked about the qualities of an ideal anesthetic. Do you think that really changes much here? No, it doesn't. You'd like to have rapid on. You'd like to have rapid off. You would like it to have minimal side effects, right? So these 2 charts are just to show you that no matter what book you look at, the results are going to be similar. The properties of an ideal anesthetic don't change. So the first class that let's kind of detail a little bit are the barbiturates, or the barbituric acids. Anytime you see the ending to a word that is ATES or ATE, you can also put IC space acid. In other words, folate is folic acid. Barbiturate is barbituric acid. Citrate is citric acid. Does that make sense? Okay. So we get this barbituric acid, this barbiturate, and we have known as nurses for a long time that barbiturates are nice, go to sleep, like sleeping pills. Okay? But we actually use them, or have used them in the past with great success as an IV formulation. There's a couple different ones we'll learn about. The problem is these are really alkaline. What would happen if this drug was infiltrated into the tissue surrounding the vein? Necrosis. Yeah, it's going to be really bad because of the alkalinity of the formulation. Now this is a weak base. I know you're going to read Ebers, and Ebers is wrong. Ebers calls it a weak acid, and it's not. It's a weak base. Huh? No, but I actually made a mistake on my slides here. I think I've changed it since then, but I was just cutting and pasting from Ebers and just didn't even think about it. I'm like, no, this is a weak acid. So guess what property we're going to discuss that you've already learned about? Henderson-Hasselbalch. We will. So, I want you to think about this. The only class that is not a weak base for anesthesia, think about all the drugs that are weak acids. That's almost everything. Think that's true? So these are weak bases. That's what I said. I just realized I screwed up again. Barbituric acids. It's an acid. These are weak acids because I've got Ebers on my mind. So, no, the formulation is alkaline. The formulation is alkaline. This is an acid. This is an acid.
So what do you mean with this formulation?
Huh? The formulation in the IV, as you solubilize it.
Then it will turn alkaline.
Yes. It's formulated at a pH of about 9.5. And you'll learn why here in a minute. It is a weak acid. Come on, Bentley. Duh. This is the oldness getting to me. It's a barbiturate. It's an acid. It's a barbituric acid. My apologies to you all. Come on, you idiot. Okay, so as I was thinking about it, I'm like, wait a minute. I know that's not true. So what are the drugs that you use usually? They're all weak bases. They're all weak bases. Opioids, local anesthetics, right? The only drugs that you'll use that really aren't weak bases, hydralazine is a weak acid, midazolam is a weak acid, barbituric acid is a weak acid, etomidate is a weak acid, and propofol is a weak acid. Ketamine is a base. Right? Ketamine is a base. How do you know if they're acids or bases? It's in the name. If the name of the drug comes first in usually the two name, right? It's a base. Morphine, sulfate. Morphine is the base. Sulfate is the acid. Right? Fentanyl, citrate. Fentanyl is the base. Citrate is the acid. Sodium thiopental. Sodium is the base. Thiopental is the acid. That is a pretty good rule of thumb to follow. Lidocaine, hydrochloride. Lidocaine is the base. Hydrochloride is the acid. Now that I have corrected myself, geez, I've got to have one every lecture, right? Every lecture I've got to screw it up one time. So barbiturates are a weak acid. Yes. Formulated as a weak base. Can that happen? Yes, it can. All you're doing is making them soluble in a solution. So these are racemic mixtures. Did you learn about that? A racemate is a mixture of two of the, they haven't separated the isomers, good. It's expensive to separate the isomers, but usually the sinister or the S isomer is always the better isomer when it comes to decreased side effects, better effects, but it's expensive to pull those out of solution. Now, thiopental is your prototypical barbiturate used in anesthesia. And you saw that first picture of it at the first slide. If you get a chance to use it, and you might, because propofol isn't always available, as you know. So you might get to use this. It comes as a solution, or it comes as a powder, which has to be put in solution. Now, why is that nice for those in the military?
Highly exportable.
You can carry it to all different types of environments. And as long as you have saline, you can reconstitute it, and it keeps its potency. Okay? Another drug that is being more commonly used than it used to be was methohexatol. It's called Brevitol. And I like to call it brief, if at all, because of its duration of action. Right? So methohexatol is another barbiturate. It's also a powder. So you have to reconstitute these in the morning if you're going to use them. So how does changing anything on this barbiturate ring give you your effects? Well, there's a couple that I want you to kind of focus on.
So what is on?
Structure-activity relationship. So you look at, so we're all checking out this ring, and I don't want you to memorize it, but look at this ring. It's got this carbon at the 2 position, and it's got this carbon at the 5 position. And if we make substitutions there, that's what's going to give this molecule its effects, its sedative effects. Now, if we have this huge branch off of the 5 carbon, according to this note, what does that say it does? Gives you a greater ability to put someone to sleep. So potency or hypnosis increases. Now, if I put this magical phenol group at position 5, and I'm not asking you to draw them out, just know the words. If I put a phenol group at carbon 5, what have I made it good for to treat?
And you're sliding into convulsant.
Absolutely. She's all over. But on that same carbon, if I don't have a phenyl group and I have a methyl group, what's a methyl group? H2. That will actually create, or could create potentially, seizurogenic activity. Now, you see that nitrogen up there? That nitrogen, if I put a methyl group on this nitrogen, I will enhance its onset or decrease latency to onset. Does that make sense to y'all?
That was the 1 or the 3?
On a nitrogen. Just know nitrogen.
Sorry, you said onset on what activity? You increase the onset for what?
Hypnosis. Onset. The effect that you want.
Increased.
You decrease the latency, right? Or increase the speed. Those terms will always get confusing. Of your onset. Now, if thiopental, when you hear THIO, am I doing okay today with the, are you tracking with me? Okay. When you hear THIO, except for that mistake, and I apologize. THIO is sulfur, 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 sulfur. If you hear a thiol group, that's a sulfur group. So thiopental tells you what? There's sulfur in the formulation. Okay, there's sulfur in the formulation. And that serves a purpose. If you can put sulfur into the formulation, you're going to enhance its potency, and you're going to further decrease latency to onset of effect, or otherwise said as speed your hypnotic effect. Any questions on that so far? Yes, ma'am. Okay, yeah, gotcha.
Why is it adding a methyl do that?
It just seems to be a property of the drug, and that's important for methohexathol for a clinical reason, and we'll get there.
And is it just because you're for some reason completely blocking that GABA receptor? So you don't have
No. So remember, I appreciate that you guys want this black and white, but you got to remember that the brain is this complex structure. And so if I change the shape of this, do you think that I could bind preferentially in certain regions of the brain versus other regions of the brain?
Sure.
It's going to, and are there different isoforms of the GABA receptor that might have slightly different site characteristics to where the GABA could bind? So realizing that, maybe, I'm just speculating here, but maybe this molecule change will bind to certain GABA receptors that stop inhibitory areas of the brain. Does that make sense? So if I inhibit an inhibitory region of the brain, what will I cause in the brain? Stimulation, excitation, seizures maybe. On the other hand, if I put a different phenyl group in there, I change its shape. I change its structure, which is why structure will affect activity. If I put a different phenyl group on that same number 5 carbon, now maybe I bind preferentially to GABA receptors that are in excitatory areas of the brain. And I limit my seizure potential. Everybody tracking that? That help now? Or did I go too much? All right. So let's look at the 2 drugs that I would like you to know. Right? So you only said 6, all right, 7, but methohexathol, there's only one real thing you use it for. So we got thiopental and we got methohexathol. And what some of the differences do you see in that molecule?
Meth versus sulfur.
What's that, sir?
Meth versus sulfur.
So we have an oxygen group here, and we have a sulfur group here. So this is called an oxybarbiturate. This is a thiobarbiturate. Okay? And what do we know about methohexathol? Well, it has methyl groups, and I can never count where they went 1, so I think it's 1, 2, 3, 4. Somewhere, but the point here is there's a methyl group on here somewhere. And what does the methyl group do to seizure activity? It increases it. So, here is the prototypical question for methohexathol. Can you think of a procedure where you actually might want to make it easier to cause a convulsion? Nope. Who here works psych?
Oh,
ECT. Right? So when you're conducting an ECT, and you give Brevitol, brief if at all, right? It seems to decrease the seizure threshold, making it easier to have a seizure. And if I'm calling it brief if at all, how long do you think it acts? It's very short acting. Perfect for an ECT procedure. Has anyone here ever seen one of them? Do you know why they put a tourniquet on the leg? All right, I'll tell you. So, just kind of fun thing here. You're going to do an ECT, you get called in, and you're going to use methohexatol, and you're going to use succinylcholine. Okay. What is the succinylcholine going to do for you? It's a paralytic. But how do you know when the seizure activity is finished if you're using a paralytic? So what do? You put a tourniquet on one of the limbs, the distal limb, and when you induce the seizure, what happens to that foot? It starts seizing. And then you know the seizure's over when the foot stops moving. So that's an ECT in a nutshell. So what drug? Barbiturate is nice for that. Methohexatol. This GABA receptor, you guys have hit it pretty well as far as I know. So you know what it does. You know it results in hyperpolarization. And you know that you're going to use 5 or 6 drugs that affect this receptor. What you might not know is that the primary site to induce hypnosis is the reticular activating system. And this system doesn't just lie in a place, it's everywhere. There's neurons of the reticular activating system all up and down the spinal cord, the midbrain, the pons, the medulla, in the hypothalamus, in the thalamus, in the cerebral cortex. It's this diffuse system. And GABA has a high density of receptors on this system. So if this system activates your awareness and you give a drug that activates a chloride channel on that system, then you take away someone's awareness. I did fix it. I said it wrong today. Thiopental is a weak acid. It is a weak acid. So, what would happen if we took this weak acid and we injected it into a septic patient? Septic patient, okay? So in order to get, so think about that. Let's start from the beginning. In order for a drug to get to its site of action, it has to be lipophilic in order to traverse membranes and get to the brain. Okay, so I need to be, if I'm a weak acid, what state, A minus or acid minus, and AH or acid and hydrogen bound, is a neutral state? AH. So that's where you want the majority of this drug as it's traveling. Right? So as this drug is traveling, you would like to see that. So you've got a septic patient, and just for example purposes, I know that this probably could never happen, but just bear with me. You give it to a patient whose pH is 6.0. All right? Just theoretically. This drug has a pKa of about 7.5. So if you use Dr. Bentley's simple chart here, you know that the pKa of the drug is 7.5. So you can put 7.5 right there in that little orange. And then you say, am I putting it into an environment that is more basic or more acidic than my pKa? So we're putting it into an area that is more acidic. So if there's a lot of acid around, Is hydrogen going to be around? Right? There's going to be a lot of protons that can bind to that acid. And is your drug in a septic patient, if you could have that magical situation, is that going to have a quicker effect or a less quick of an effect if I give it to Jeffrey here? His pH is 7.4. And why is it quicker?
Because more of it is staying in the neutral state.
More of it has bound to a hydrogens that are floating around and is at a neutral state, right? It's the same premise as why you take aspirin in your stomach versus injecting it. Because it's a weak acid. Acid likes to have an acid to stay neutral. A base likes to have a base to stay neutral. Does that help? That is pKa in a nutshell. That's Henderson Hasselbalch in a nutshell. So where are most of these drugs that were on that chart at the beginning, where are they metabolized at? Liver. When in doubt, say the liver. Hepatic. Right? So if you've got a patient in liver failure, what's going to happen to this drug? It's going to stick around longer. Also, if you've got a patient in liver failure, what does the liver make that helps to buffer things? Albumin. It's a protein. These drugs are protein bound. And if you have less of a protein floating around, do you have more or less free fraction of a drug floating around after a dose? More. That's how you have to start thinking. Okay, if this organ isn't working, what is its normal job? And now, how is it going to affect the kinetics and dynamics of the drugs that I'm giving? So I've got this thiopental. It has a pKa of 7.5, 7.45, 7.5. What's the body's pH? 7.4. So as soon as you inject it, what do you know? The majority of it, almost half of it, is going to be neutral and able to distribute very quickly. Now think about this. This is one of Dr. Bentley's abstract ideas, so stay with me. I inject 100 molecules of thiopental, and within 30 seconds, 50 of those molecules distribute into other compartments. Is pKa and pH, is that a static environment? So as soon as those 50 molecules distribute and the pH of the blood is still 7.4, what happens to the other 50 remaining molecules in the blood? They will, half of them go to a neutral state and the other half will stay in a charged state until what happens? Now they distribute. So it is that idea which terminates the effects of these drugs so quickly. You get out of the bloodstream very quickly, you redistribute to other areas, and although you might be sleepy when you wake up very quickly, within 8 to 15 minutes, because of this constant redistribution. So this rapid termination is an effect of this redistribution. Now the way you look at this chart, you can think of a barbiturate that is administered, okay, and at time 0, 100% of it goes in. And then immediately it distributes to certain compartments. And that's what this is trying to say. So when you're saying, sir, what does all of this mean on the left-hand side? Okay. Imagine a scenario where you inject it and it immediately goes to its areas of preference. So 30% of what you injected goes into the vessel-rich group, 30% of it goes into the blood, 15% of it finds its way to the muscle group, but imagine that that happens instantaneously. So that is what that chart is saying. And so then you give it, and then you just see what happens. You start doing serial blood draws from the person, and you start to see the levels that remain. And what do you see? Well, you see over time, where is most of this drug going in the first 15 minutes? It's redistributing. The muscle is a huge compartment, right? Where else is it going? It's going to the fat. It's leaving the blood. You see how that yellow drops dramatically? And if it's not in the blood, where else is it probably being taken from? The brain. Because what has been created in the blood? A gradient. And the liver starts to metabolize it, further depleting the stores from the compartments. Everybody have a decent idea of that graph, at least initially? Okay. So we talked about this CNS depressant effect of the barbiturates. Now, there's something about thiopental that you should know. This is kind of a weird dose, or a weird dosing phenomenon. If you give thiopental in a laboratory preparation of a cell with a GABA receptor, and you can look at it, and you give a subtherapeutic dose, a small dose, it actually, at that small dose, will allosterically modulate the GABA receptor. So the point there is, at a small dose, subtherapeutic, it appears that this barbiturate will allosterically modulate the receptor. It doesn't directly open it, it just makes it more efficient for when GABA ultimately binds to the GABA receptor. But, interestingly, at higher doses, it will find its way to the active site and directly gate or directly open this chloride channel. So there is a dose phenomenon with thiopental. Everybody tracking that? Here we go. So we give low-dose thiopental, it binds, and nothing happens. Because when something is allosterically modulating something, all that means is that it binds to a site other than the active site and creates a situation which is more efficient for this receptor. So now when GABA comes around and binds to the receptor, has a higher conductance and it stays open longer. That's allosteric modulation in this kind of context. Tracking? So now when GABA comes along, then we get the chloride that comes in. So we got that, and you get the hyperpolarization. But now let's give thiopental at induction doses. Let's give propofol. Let's give etomidate. And what's happening? Well, the drug binds and the receptor opens. Okay, that is a direct gating, directly opening the receptor.
So,
Yes.
so clarification on that. So in order for thiopental to work, it needs the GABA. So it will not directly open the gate
At low dose.
At low dose.
Subtherapeutic, subclinical
Okay,
doses.
so at high dose, it binds just like those
Induction
second slide,
doses.
boom, it's in.
At
At
therapeutic,
therapeutic dose.
clinical doses.
Got it. Thank you.
You bet.
All right.
Now think about what a barbiturate does. And think about where GABA receptors are. Do you think GABA receptors are on most cells? Yeah. We all come from the same cell. And one thing that I learned quickly in your seats is that a receptor can be on any cell in the body. But what have we done? We have specialized cells to act a certain way. And so, for example, if I want to breathe, I have a high density of beta receptors in my lungs. But it doesn't necessarily mean that there's not GABA there. It doesn't mean that there's not the NMDA receptor there. It doesn't mean there's not serotonin receptors. But my body has specialized my lung cells to have a high density of a certain type of receptor. So when you think about this, if you talk about an excitatory area of the brain and you say the glutamate system, granted, those neurons that you're speaking of might have a high density of glutamate receptors, but they're still going to have these other receptors, just at lower densities. Does that make sense? So that helps when you think about the context of these drugs and all of these. Well, sir, you say it does this, and it does this, and it does this, and it does this. Well, yes, it does. You're going to have a predominant effect, and then you're going to have other effects. Here are some of the other effects. So think about this. If I'm on a glutamate releasing or an AMPA releasing neuron, if I'm on a neuron that likes to release all of these excitatory molecules, and I can activate GABA receptors at the axon terminals, what am I going to do to my ability to release those neurotransmitters? If I hyperpolarize the nerve terminal, what do you need for vesicular release of substances? Calcium. So if I open a chloride channel and I create an inhibitory postsynaptic potential that fights with that excitatory postsynaptic potential from the action potential, I'm decreasing my release of my neurotransmitters, right? I'm decreasing that vesicular release. So I also will indirectly inhibit AMPA activation postsynaptically because I don't release my neurotransmitters. We'll get to this slide. We'll take a break. And that same point is true for bullet 2. All right? I showed you how barbiturates can modulate other sides of the benzodiazepine or GABA receptor. And so with that, there appears that it might enhance the effect of your benzodiazepines. What that means is, if you give midazolam and you give thiopental, your effects may be synergistic. It's just that simple. The point I would like you to remember, though, is that barbiturates directly can activate the GABA receptor and then inhibit the function of the excitatory AMPA receptors. Now, you've probably never heard of an AMPA receptor. It is a glutamate receptor. What else have I told you today is a glutamate receptor? The NMDA receptor. So if you hear NMDA, if you hear AMPA, and if you hear kainate, Kilo, Alpha, India, November, Alpha, Tango, Echo, those are all glutamate excitatory receptors. I'm just saying that now in case you see it in the future. Take a break. They can be. I missed that. I missed the point. Liver failure. Right?
Okay, yes.
If you're not making out human.
Yeah.
Like, and you say you have 50% of a drug that's protein bound, but you have less protein.
Then there's more drug in the system. So
There's more free fractions.
Free fractions are available for distribution.
There you go.
Thank you.
You bet.
Structure affecting action. CH2, that's an okay.
So if I put a phenol group on here, now it has anticonvulsant.
Okay. What does the phenol group look like? So,
I want to say it's CH3O, but I have to look.
okay. And so the structure of the molecule, is that just
Just little changes on
the way it behaves in its volume?
Yeah, because remember the lock and key model? How that key looks is going to interact with the lock.
Okay.
And so if you make small changes to this ring, you actually change the structure of that protein.
Okay.
And if you change the structure of that protein, you're going to change the way it fits it.
Okay.
And so that's the big point.
So like the sulfurization and increased potency and speed. And is that more just related to the type of bond and then where it actually binds to the receptor site?
And the fact that that change will change the pKa.
Okay.
That change will change its polarity.
Kind of change, potentially changes composition.
And then change its potency. Because it'll make it more lipid soluble.
Okay.
And the more lipid soluble you are, usually, the more potent you are.
Sweet. Thank you. Do you know what the password is for that quiz? If I can make it quiz 3. Really green force. Sure it's not.
You look quick.
Which,
I'm only going to do the last 3 questions to the one side, just to be fair. Okay, I'll go back tomorrow.
Do it tomorrow.
Okay, fair enough. I can find it.
So that's okay, I just wanted to make sure I had it right. We've done this twice now, it was, it's not the way. No, it's fine.
So you may have to re-hit the pH thing on that. Just really quick.
Yeah, that's true, though.
Well, because then I went back to, yeah, because I wrote down whatever number I wrote down.
I think I made that point clear.
Yes. Because I think the theory was, I think we got down to the point where it was weak acid. It said the pH of about 9.5.
That formulation
The
is,
formulation itself, so if it's in a powder form, it's in a basic form. We constitute.
it'll turn the pH of 9.5, but the pKa never changes. You can be a weak acid in a basic environment.
Okay, so when we say it's a weak acid, when we say it's a weak acid,
Why is it nice to put it in base? Think about this. If I want to solubilize water, I know that water is this component of multipolarity, right? I've got these dipoles with a little oxygen molecule. They dissociate, you get positive and negative. So if I'm a substance and I want to be a solvent, I want to be solubilized, water is my solvent. So if I can formulate this powder to be very basic, and I have the drug in there, so now what, in the basic environment, what happens to the, if I put water in this, we'll say my pH is 9.5, what is that telling you about what's in what the drug is doing now? Is it more in the A- form or the AH form? Because it's basic, there's not a lot of hydrogens. It's in the A-. And so since it's in the A- form, it's going to be present to a H positive and soluble. So that formulation helps you put it into solution. And then when you inject it, the pH of the body overcomes that change very quickly because you're putting, what, 10 cc's of a pH of 9.5 into a huge volume of 7.4, so it's going to change your
Protons from the body and turn itself into a non-polar moieties that it can cross the.
That's exactly how it works.
Okay. So like barbiturates acid is a weak acid.
It is.
But we turn it into a base so that the body.
We turn it into a base so we can put it in solution and inject it. That's the only reason we're putting it into a base.
PKA was classified as a weak acid.
Yes.
PKA was 7.7.
The PK, no, don't.
Okay.
Generally, yes, but so the PKA at 7.5 is pretty basic,
Yeah, so pretty basic.
but that's still a weak acid. Why is it called a weak acid? Because what does it like to do? Likes to give up its protons. And that's what it favors to do versus hold them. That's the only thing that makes it a weak acid.
Just to check on one thing. Racine is
Vicky rectus and Vicky sinister racine.
so these are actually formulated to be racine. It's not just like that. They isolate mix, whatever happens to be.
All right, I think it's time to start again. Just to touch on that weak acid, weak base thing again. Now that I've overcome my senility, so sodium thiopental is a weak acid. But it's pKa, sir, at 7.5. That's kind of basic. Yeah, it is. You can have a basic pKa and still be a weak acid. Because what is the definition of a weak acid? So thiopental's preference is to give up its protons. That's what makes it a weak acid. Not its pKa, not anything else like that. Just the fact that it likes to give up protons when given the opportunity. It just so happens that its pKa is 7.5, roughly, and we're 7.4. So it's nice that when we inject it, we're slightly more acidic than the pKa of the drug, meaning more of that drug will find a hydrogen, bind to it, and then become neutral. And what do we know about neutral molecules? They're lipophilic. They cross membranes. They're potent. Okay? But, sir, why is it formulated as a base? Purely to get it to be soluble in solution. To be able to mix it into an IV formulation and inject it into the vein. That is why it's formulated. When you reconstitute it, the pH of that solution will be 9.5. And that is solely to get more of that acid in the A- so it can bind to one of the hydrogen molecules that's in the water and be solubilized. Right? But it still is going to be a pretty basic environment, which is why if you inject it into the vein and it gets out, the formulation is what hurts the body, not necessarily the drug. Right? It's that caustic pH of the formulation. And I'm here to tell you, if you ever inject it into a vein, or if you inject it into an artery, you may have to take a measure to relax that area, because you could cause some severe necrosis with that caustic pH. Moving on. Does that help, sir?
Yes.
So what is your IV induction of thiopental? Well, it's between 3 and 6 milligrams per kilogram. And the thing about ranges, if you pick a number in the middle, it's easier to remember. Okay? If you pick a number somewhere in the middle, it's easier to remember. Benjamin, how fast is one arm to brain circulation? Less than that. 15, I would say 10 to 15 seconds is one arm to brain circulation. So you inject it, you put it into the antecubital vein, it moves into the right atrium, or into the vena cava, into the right atrium, down into the right ventricle, up into the lungs. Some of it may or may not get filtered, comes into the pulmonary vein, into the left atrium, the left ventricle, out the aorta, and up the carotids. All of that, it's about 15 seconds. Not very long. ED95. Brian, what does that mean? So say it to me in clinical terms.
If I give that dose, 9 out of 10 of the people that I give it to, it's going to work on.
And in this case, what does work on mean?
It's going to cause
Hypnosis.
yeah,
Hypnosis or sleep. So 3.2 milligrams per kilogram, 95% of the population will go to sleep. Now, this drug has a weird property as well at subhypnotic doses. We already learned about the allosteric modulation at subtherapeutic doses. But if you give a low dose of thiopental, you will actually increase pain perception. It's a weird property of the drug.
Is this what they give for the lethal injection?
Maybe,
I think so, yeah.
but they give a therapeutic dose.
Yeah.
Yeah, they're giving a therapeutic dose.
Isn't that like the truth serum stuff too?
Well, that was Barbiturates. Yes, sir.
It seems like if so, ED95 is 3.2, but the dose range is 3 to 6. It seems like it's on the real low side of its dose range. Wouldn't we expect to see that more like 4.5 or something? Or
Well, this is just ED95 of the number of people they've sampled. I'll say that.
okay,
But what does that say? That it actually is a pretty good dose, and that you're going to have 5% of the population that's going to act funny. All right? And that's not abnormal. You're going to have 5 out of 100 patients that don't read these textbooks. And so you give them 20 cc's of propofol. They're still awake. You have to give them another 20 cc's of propofol. They're still awake. But that is a minority of your patients. You give most people this dose, they're going to sleep. So yeah, I get what you're saying.
Is there a rationale that we know of for the hyperalgesic effect?
That would have to do with, in my opinion, speculation, the descending pain pathway, and you'll get that later on in the year. So if I give thiopental, what do I do to your EEG? Anybody here ever put someone to a barbiturate coma? So that means you've made their EEG isoelectric, right? You've flattened it out. So that's all that this is saying in this slide. You can give enough barbiturate to stop brainwave activity. A dose-dependent latency to sleep decrease, that just means the more you give, the quicker they go to sleep. That's a dose-dependent latency decrease to sleep. Now, this sleep may not be a very good sleep, may not be a very restorative sleep, and that's exampled by the decrease in the rapid eye movements. We spoke about anticonvulsant activity. Now, I told you that methotrexate may decrease the seizure potential or seizure threshold, and therefore it might be your textbook answer for electroconvulsive therapy. But think about that. That's at a dose. But if I give a bunch of a GABAergic agent, and I start to give more and more and more of it, eventually, a drug like methotrexate will stop seizures, right? It's just that initial dose that seems to decrease the seizure threshold. The point there is that most, if not all, of these barbiturates have somewhat of an anticonvulsive property. That may depend on the dose. Now, thiopental at normal doses is an anticonvulsant. But thiopental contains what in it? Sulfur. if you have a sulfur allergy, or you know someone who has a sulfur allergy, you might want to be careful of using this drug.
Would you consider it a contraindication or just a caution?
I just don't use it. You know, there's you got contaminate with propofol, you can use if you need to. So, can you understand why if I activate a GABA receptor and I increase chloride conductance into the cell, how I would decrease my requirement for oxygen? If my cell is quiesced and my energy factory isn't running, I don't need to turn the lights on, right? I don't need the oxygen. As well, unlike the inhaled agents, I give a barbiturate and I actually decrease my cerebral blood flow. Because the barbiturates will have more of a vasodilatory effect. All right? And ultimately, at least for 10 minutes, that initial induction dose, you will decrease cerebral blood flow. Now, if I decrease my CMRO2 and I decrease my cerebral blood flow, that's not bad for a brain-injured patient, right? That's not that bad. I actually can use that to lower my ICP. And this used to be a drug that was titrated many, many times for neuro patients on a neuro ICU. In fact, still may be in some places. Now, this is, yes, sir.
So is this your CP or like your central venous pressure? Is that what
No.
Okay.
Oh, this right here?
So I've never seen it. I've only seen ICPs, never seen that.
So this is true. Think about CVP. So here's what you have to remember. CPP, cerebral perfusion pressure, is usually said as MAP minus ICP. But the thing you have to add now, or right atrial pressure, whichever one is higher. So if your CVP is higher than your ICP, what's happening to the blood? It's backing up, it's backing up, it's backing up, it's backing up. So if your CVP is higher than your ICP, you're pushing against the higher pressure. So things are just going to back up in your head, and your ICP is going to go up. So you see those RTs that tie those neck collars around? That's bad news when it comes to neurotrauma. Why? Because that's going to make your venous pressures high and greater than your ICP, and the blood's not going to be able to flow out of your brain. Does that clarify that? One of the bad things about barbiturates is if you take pentobarbital every night to go to sleep, and you have to keep taking it, keep taking it, keep taking it, eventually you'll build a tolerance. Have you discussed tolerance, the receptor up and down regulation?
Yes, sir.
So if I continually provide the body with a drug that stimulates a receptor, what will happen to the amount of that receptor in the body? It will decrease. Then I have to give more drug to get the effect. And you're like, well, if I have less receptors, why do I need more drug? This is how I look at it. If I have a squad and I'm going in the woods, it's easy for me to find a battalion, right? But if I'm a battalion and I'm going in the woods, it's harder for me to find a sniper. Right, I've got to search around, and what's going to happen? The sniper's going to start picking all over, and I start to attrit. So think about this. I am this receptor, and I have been removed, a certain amount has been removed out of my body. So now I'm this drug, and I'm in the blood, and I'm searching for this receptor. I'm searching for this receptor. I can't find it. I can't find it. And then what happens before I can find that receptor? It's chewed up. It gets metabolized. It goes away. Right? And most times you need to occupy a certain percentage of receptors in order to get your effect, right? So now you have to have less receptors, they're harder to find, and you still have to bind the same percentage to get your effect. So that's why downregulation, you have to increase your doses. If that totally confused me, see me offline. Are we okay with that? All right. Now, if I depress my brain function enough, I know that my cardiovascular centers are there, my respiratory centers are there, and so if I give a drug that activates the GABA receptor and chloride ions move into a cell that's in a group of cells responsible for my breathing, you can see after a high enough dose that you would become apneic. Now, unlike the inhalational agents, these barbiturates will depress both rate and volume. As well, if I sedate the brain, what do you think happens to my brain's reaction time to hypocarbia, to hypoxemia? It's going to be blunted. That's what that means. So that's kind of barbiturates in a nutshell. This is thiopental, a specific barbiturate. And you may see it in these Bristagets. So it'll come in this white Bristaget. That's what that package up top is. And then you have to take it apart and screw in the glass part into your Bristaget. And in that usually has 500 milligrams. So if I'm 70 kilograms and my dose is 3 milligrams per kilogram, and this has 20 cc's in it, how much am I giving? So I need to give 210 milligrams, and there's 500 milligrams in this thing. I'm roughly giving roughly about 8 to 9 cc's, yep. That just gives you an idea of how much you would actually use from this Bristaget. Change this. Change this. It is not a weak base, Bentley. This is where I screwed it up. This is a weak acid. Cross it out right now. I'm going to jump up and down and make a lot of noise. The thiopental is a weak acid. Weak acid, weak acid, weak acid. Change it.
Can we count on that being a quiz question tomorrow?
Yes. Then I put it in solution. And why am I putting it in solution? So I can inject it, because it's hard to inject the powder, right? So I have to put it into solution. But in order to put it in solution, I have to make the environment basic, right? So I put this weak acid in a base, and now it is in a solution that I can inject. That is why you're doing that. Problem with that solution now is that it can become caustic if it's out of the tissue. That's about the 4th time I've said that now, isn't it? And this is the 2nd time I'm talking about albumin and IV agents. Because that is a huge concept. If you can't have plasma albumin, you're going to affect the free fraction of many of your drugs. Now, unlike propofol, this caustic pH makes it hard for bugs to grow in it. Ultra short acting. Why is that, Shannon? I give this drug. Say it. Keep going. So what does that mean? So it redistributes quickly, right? And what is responsible for your termination of action? Redistribution. That doesn't mean it's out of the body. It's just not in the blood to have an effect on the brain. Okay? But if you give a dose after dose after dose after dose, then it might build up. And then you might get sleepy and have this hangover effect that's extended. I can see that. If you're in the recovery room and somebody has gotten thiopental, they may say, my mouth tastes like an onion, or it's like garlic. Huh? So where is thiopental metabolized? Exactly. Sweet. So look at this one. If my respiratory parameters, do they increase or decrease with thiopental? Decrease. I think everything decreases here. Yep, pretty much. So your CPP decreases, your cardiac output decreases, your SVR decreases, your uterine blood flow decreases. Your cortisol levels will be temporarily suppressed. This is what happens when you activate a receptor that has an inhibitory effect, because GABA is the major inhibitory neurotransmitter in the body. So, cerebral perfusion pressure is maintained. I wouldn't worry too much about that question. But what does thiopental do to the EEG? What's a clinical application of that? Barbiturate coma for brain injury, right? And if I put someone in a barbiturate coma, what do I do to their CMRO2? Greatly decrease it. And that's beneficial because if the neurons are quiesced, they're not going to require oxygen, they're not going to require blood flow, and they're just going to be kind of in a state of hibernation until the brain can heal. So some of the contraindications of thiopental, one would be asthma, a relative contraindication. Another contraindication is AIP. So acute intermittent porphyria is a problem with heme metabolism. This is all you need to know. And as a result, you get this buildup of the heme, and you end up getting this flank pain. So if you give thiopental, you can make that situation worse. And the pain becomes severe, and then it can create other problems. But AIP, acute intermittent porphyria, and thiopental do not mix. Because thiopental further inhibits the body's metabolic processes. Yeah. Yes. Because where is this metabolism occurring? No. Where does thiopental get metabolized? Where's the liver located? In your flank. Any questions on thiopental? All right. Methohexatol. Where did I say this has a place? ECTs. Okay. So we know that. Now this is a weak acid. And look at its pKa. It has a basic pKa. But what is the only thing that makes it a weak acid? Its ability to give up its hydrogens. That's the only thing that makes it a weak acid. pKa is a separate issue. Methohexatol is bound to albumin. So if you have someone with liver failure and you give a dose of methohexatol to that liver failure patient, and then you give a dose to Tristan here, right, per kilogram dose, who's going to have more of a free fraction of drug floating around in their body? The liver failure person. So one thing about methohexatol, known as Brevitol, otherwise known as briefenol, is that it is extensively metabolized even more so than thiopental, and that the liver has a higher extraction ratio for Brevitol. That's what it's also known as, Brevitol. And so you give it, and it goes away pretty quick, much quicker than thiopental. That's it on Brevitol. So guess where the question's going to revolve around? No, ECT. No. If I say Brevitol, you say ECT. The question is, why do you say ECT? Because it has the ability to lower a patient's seizure threshold. Okay. Who here has used midazolam? Just about everybody. Would you believe I had never used it before I came to this program? I knew PIT and I knew magnesium. That was it. I was OB. Loved it. So benzodiazepines, how do they work on the GABA receptor? Is it a direct activation of the receptor? Is it a direct activation? No. So it is an allosteric activation. And what does that mean? Yes. So midazolam will bind to a different site other than the active GABA binding site. And when it does that, it sets up this channel, this receptor, to work better when GABA actually finds its way around and binds. So now your channel stays open longer, right? And the GABA will stay bound just a little bit longer. So as a result, what happens to you? You go to sleep. At least that receptor stays that way until the benzodiazepine displaces itself. And what will determine how well benzodiazepine will displace itself, as with any other drug on a receptor site? What determines how long it stays bound? It's concentration gradients, right? If I have a lot of a substance, if 10 of us are fighting for this seat, someone's always going to be in the seat, right? But as soon as I start taking away 10 of these people, and if I got one person in the seat, they may not stay bound as long.
So can you get back one slide? With that color coding system you said you're going to test this on, how does
Oh,
this
no,
play?
this is just a picture of the orange. You're going to see the orange labels. Your tape to put on your syringe is always going to be orange. It says Versed. Now this vial may be green, right? But the label that you have on your anesthetic cart is always going to be orange. The label that you have for thiopental will always be yellow. The label that you have for propofol will always be yellow, no matter what it's packaged in. But the tapes that you have, that's what I'm talking about. So this should look easier, or this should look familiar to you from the thiopental slide. And what this is again saying is that the benzodiazepine will find its way to the site other than the GABA site. And when it's bound in the absence of GABA, when there's no GABA anywhere, I put a benzodiazepine on that receptor and nothing happens. You guys tracking? But that receptor is set up to work better when GABA comes around. So that is a note that GABA has to be present for this to work. But sir, you said that barbiturates can do the same thing at low doses. And you're absolutely right. But the difference between the barbiturate and the benzodiazepine is that there's another property of the barbiturate that, if given in sufficient doses, will actually activate that GABA site and open the receptor. Here's midazolam. Nothing happens. Here comes GABA. GABA binds, and now that channel opens, and here comes the chloride. We've hyperpolarized the cell, and we have quieted down the cell. So what kind of a system do you think that the benzodiazepines will help modulate? The RAS. And there's GABA receptors everywhere. So any GABA receptor that it finds, it will bind to the allosteric site. And if there is a GABA neurotransmitter in the area, that region of the brain will quiesce. Now, the one question that always gets asked, if I give this, what kind of amnesia do you give the patient, Pat Richards? So go ahead and read the top. What does that mean? So yeah, so you forget everything from the time you give it until the drug wears off or it doesn't have an effect. But it doesn't remove memories that you've had before them. It's not retrograde, it's I give it anterograde, moving forward.
Does that include like the 5 minutes just prior to administration?
Mhm.
I always thought that's what retrograde meant.
Nope. Nope, it is anterograde amnesia.
Okay.
Can you understand why it could be an anticonvulsant as well? Right, GABA system. So another clinical point, kind of early, you get called to the PACU. You want to do a regional block on a patient. I'm your staff that day. And I say to you, I want you to give 5 milligrams of midazolam to this patient. Right? Why did I have you do that? A, I don't want this guy or girl to remember me putting a big needle in them as we shock them and look through the ultrasound, right, the nerve stem with the ultrasound. And B, I'm going to take advantage of the GABA properties of the midazolam in case I give an intravascular injection of local anesthetic. Anybody here seen a local anesthetic seizure? Well, if you, by chance, or you will, if you do enough regionals, you'll see it. The patient may start to convulse. But have you given protection, relative protection, by giving that dose of midazolam? Yes, you have. Now, do you get muscle relaxant activity with midazolam? Not directly, but indirectly you do. You will indirectly, because you will inhibit or you will activate GABA receptors, which will inhibit the firing of motor neurons coming out of the spinal cord. And so if I inhibit the function of motor neurons leaving the spinal cord through the rami that I saw you were learning about today, right? Then you will relax muscle. If I give benzodiazepine, I decrease your latency to sleep. I make it easier for you to fall asleep. Again, it's not a very good sleep, as REM movements are depressed. So if you're thinking that taking a benzodiazepine or propofol or thiopental is a way to fix your sleep, it's not going to work. Exactly. Now, there's not real good literature on this. Some studies indicate that at certain doses, midazolam may have pain-relieving properties, and that at other doses, it may have pain-causing or anti-nociceptive properties. Or nociceptive properties, not anti-nociceptive properties. Kind of like that with thiopental. But if you are able to give benzodiazepines directly into the spinal cord or directly into the brain, you will see pain-relieving effects, anti-nociception. How do Midazolam. Romazicon, otherwise known as flumazenil. Good. Now look at this common theme that's coming up. If I give benzodiazepines in a dose-dependent fashion, just like the barbiturates, what's going to happen to CMRO2? It's going to go down. And what's going to happen to cerebral blood flow? It's going to go down in a dose-dependent fashion. The more you give, the more decrease that you see.
Hey, sir.
Yeah.
There's a bullet on the crazy slide with the guy that's holding his head. And we've all done it like that, moderate sedation or conscious sedation with the benzos and the opioids. Is it, we gonna get more into that, like that relationship, or is that
Yep.
something coming later?
That's synergistic. So, check this out. If you're with me in the OR, I won't let you take an opioid to the PACU or the pre-op area. I'll let you take your midazolam, or I won't let you take your midazolam, but I'll let you take your opioid to the pre-op. Right? Because you can give a lot of midazolam by itself, and it's hard to make patients go apneic. And you can actually give a lot of opioid by itself. You really can. And it's hard to really make a patient apneic. But as soon as you combine those two together, all bets are off. Right? Because 1 and 1 in that case may equal 6 in some patients, and it may not affect other patients, but you never know. So people that routinely give 2 of Versed and 2 of fentanyl, going to have 5% of that population that is going to go apneic on you in the pre-op area. Right? And so I avoid it altogether. I leave my opioid in my cart, and I start to titrate that once I have them in my neighborhood. My neighborhood is the OR, because I have the tools that, if they go apneic, so what? I'm going to make them that way anyway. But it's kind of bad style to make your patient apneic in the pre-op holding area and go tearing down the hallway and kind of, not cool. Intraocular pressure, you can imagine that if you give something that's going to inhibit things, that this would decrease intraocular pressure because you're going to decrease your ability to create things. And now, here is that point that we just talked about. If I had my choice to sedate patients and keep them breathing, and the only two things you gave me were thiopental and midazolam, so in this magical situation, my choice to keep a patient breathing would be to use benzodiazepines. And according to this chart, why would I continue to give benzodiazepines and avoid giving the barbiturates? It plateaus. Right? It's a little bit harder to give enough of a benzodiazepine dose to make someone apneic. You will get changes to their respiratory parameters, no doubt. But to make them apneic, that's kind of hard. Whereas you give barbiturates, and it's dose dependent. You give enough, they're going to quit breathing. Okay? So what happens if I give midazolam to this preoperative holding patient to their tidal volume? It decreases. What happens to their respiratory rate? It increases. How is that different from the barbiturates? They both decreased. Okay. So this healthy patient that's in the pre-op holding area that's coming for your orthopedic procedure or whatever it is, okay, they maintain their minute ventilation. But as soon as you give a cc or 2 of fentanyl, man, that rate's going to slow down. They're going to get a little bit hypercarbic. Right? And usually, you get by with it. 95% of the population, you're not going to have an issue with that. I'll give 2 of Versed and 2 of fentanyl. No big deal. Yeah. Just that one time, right? You get failed for the day because you didn't titrate your narcotic or Versed. Yeah.
So most of the orders you give your PACU are opioids.
Yes.
And so how do you keep the synergistic effect from that? Wouldn't you just always choose your opioid to go back to?
You could, but how long are your typical procedures? A couple hours. You give Versed preoperatively. your half-life is not that long. Right? Yes, you do get a synergistic effect, but by the time you take them to the recovery room, what have you been doing? You've been titrating opioid, you've been having this general anesthetic on board, and you're able to see your respiratory parameters. And so you'll write your order based upon your experience in the OR. I'm giving them a ton of fentanyl with the gas on board, and they're breathing at a rate of 8 per minute. That's awesome. So when I get the gas off, they start going to 14 per minute. So I could use this opioid and they'll relatively maintain their ventilation. And when you see this, you'll understand when you would choose morphine, when you would choose fentanyl. It's going to make more sense when you get there. But here the point is, you mix opioids with benzodiazepines, your respiratory parameters are not always going to be okay. So like the barbiturates, if I give a drug that inhibits my respiratory centers, what will be my response to hypoxia? It'll be blunted. And apnea may occur with induction doses of midazolam. I would like you to look up what an induction dose of midazolam is. It's a lot. We're talking 30, 40, 50 milligrams. Can you understand why you would want to be cautious in using these drugs in respiratory cripples? And that's not just these drugs. Any drug that will affect your respiratory parameters, you need to be careful with respiratory cripples. Now, by themselves, you have a very modest effect on the cardiovascular system. But again, when you start to mix them with the opioids, you will see a marked drop in SVR. You'll see a marked drop in possibly cardiac output. And if you give an opioid, imagine this scenario. You gave midazolam, and maybe your pressure dropped a little bit, but your heart rate compensated for it. Okay. Now this magical scenario, then you give an opioid. What is an opioid going to do to your heart rate? It's going to decrease it. So that kick you got from the rate just went away. And that's not the only thing that the opioid is going to be synergistic with. The opioid is also going to affect your smooth muscle, your vascular smooth muscle, and you're going to vasodilate even more. So, how did we get midazolam? This drug is in formulation, right? It comes as a water-soluble formulation. So we used to use diazepam, and that diazepam, the Valium, would last a long, long time. And I'll be honest, I've never used diazepam. I've always used Versed. But propylene glycol is what the drug diazepam used to be in, and what is a problem with propylene glycol? Antifreeze. It is actually antifreeze. But you can put drugs in this and it'll solubilize and you can inject it, but it hurts when it goes in. It hurts a lot. So, the chemist said we need a shorter acting benzodiazepine. But all of the short acting benzodiazepines that we have are hard to get into formulation. But then one of these guys discovered that, well, if I formulate it at a certain pH, it'll be soluble in water. And then if its pH changes, it'll become soluble in fat, lipid soluble. So what happens? They come up with this midazolam, ring. And when the pH of the solution it's in is less than 4, it is water soluble. Why? Because a ring breaks off and you have polarity now. And because you have polarity, you can bind to water molecules and the water becomes a solvent now. And so it's in solution. But then you inject it into the blood. And the blood has a pH of 7.4. for our purposes. That ring closes up. When that ring closes up, it becomes lipid soluble, meaning that it can do what now? It likes to pass through membranes and gets to the area that where it needs to work. So that is midazolam, and it's been one of the greatest things since sliced bread for preoperative sedation. Has anyone ever given benzodiazepines and seen the paradoxical reaction that comes with it? Especially in kids. You may give it. I gave it to a. Actually, I didn't give it. So I was working. First time I ever saw this. I'm in the PACU on my OB floor in New York. Anybody here ever watch New York Med on Thursdays? That's the hospital I used to work at. So we're in the recovery room, and this patient starts to go crazy right after they gave her some midazolam. I mean, she was jumping out of the bed, trying to leave. She was having this hysterical reaction. And in a certain amount of patients, that 5% or so, you give this drug, and you will see the opposite reaction of what you're looking for. They'll get hostile. They'll get aggressive. They're going to be disoriented. So just remember that.
Did you reverse them?
Well, so in that instance, if you can relate it specifically to the Versed, at the time I didn't even think about it, I would have given some romazicon or flumazenil had I been the anesthetist called to come in and help. Yeah.
Is that typical?
So extremes of age, definitely.
It's really awesome when it makes you like some down or everything else.
Do you hear what she's saying? So I said kids. She said elderly. She's absolutely right, and I'm right. The extremes of age is where you'll see this. And what do you know about extremes of age? Their squash just isn't quite right yet, right? The kids aren't developed, and the old guys are starting to decay. So when you are being in the sim room with some people, they may have you titrate a 0.5 milligram to 1 milligram a little bit at a time. I'm not saying to use my example, but because I don't mix my opioid until I get to the OR, I'll give a higher concentration of midazolam preoperatively. So you may see me titrating 2 milligrams at a time. This is just for you guys. Start low until you get experience with it, and then as you start to work more and more with this midazolam, you can titrate it higher and higher and higher. Some of you may have already been titrating it higher, 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 maybe feeling comfortable with it. All right, we'll discuss this tomorrow. Thinking maybe 10-ish, starting to come in here at 10. We'll stay in as long as you guys need. And I literally mean as long as you need. Well, we'll actually just kind of go through the slides, and if it's probably an area of importance, and we'll go over that area. And